Okay, well, hello everybody. I'm Gregg Stone, and I'm here with my friend and colleague Jang from Boston, and we just completed a very interesting session on the detection and treatment of vulnerable plaque here at the 30th anniversary meeting of TCT Asia Pacific. So we're going to review some of the concepts we discussed, and we have an esteemed panel here with Jung-Min, Takashi, Kubo, and Akiko Maehara. So maybe I'll start it out with the first question to our panel. And how do you define a vulnerable plaque? Is it a pathologic diagnosis? Is it a clinical diagnosis? What is a vulnerable plaque?
So I usually use a pathologic definition. It's prone to coronary thrombosis. So if we use an event including the unstable angina, we usually use a clinically high-risk plaque.
Okay, so pathologic diagnosis of a thrombosis-prone plaque.
Yes.
Dr. An?
Sorry, using what modality do you make a pathologic diagnosis?
Well, pathology, autopsy, right? If it's a pathologic diagnosis, it's an autopsy.
But ultimately, you need tools to make a diagnosis in living patients.
Okay. Well, we'll get to that, right? What are the next tools? But what do we just diagnose it? So, Dr. An, is there a clinical diagnosis of a vulnerable plaque?
As for me, I think the vulnerable plaque is a kind of clinical diagnosis. Any kind of plaque, if it causes the acute coronary event, I think it is a vulnerable plaque. So.
And what clinical events would you consider to be important?
So the most important is sudden death. The second is thrombus formation and non-STEMI. And third important clinical scenario is the unstable angina, the requiring admit the emergency department or hospitalization. I think this is the most important event.
So we think we know what a plaque is pathologically that is a vulnerable plaque. As you know, Dr. Jang has done seminal work showing that it's not just a thin cap fibroatheroma. Those are the ones that are prone to ruptures, but there's also erosion-prone plaque. So if I can actually be so bold to ask you a question, what is an erosion-prone plaque? Why do some plaques lead to surface erosion and thrombus formation?
Unknown.
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 Simple one-word answer.
Yeah, so as I mentioned during my talk, if you were to find TICFA, well, rupture is responsible, let's say 50%, erosion 40%, eruptive calcified nodule 3 to 8%, let's say 10%. Then if you have 50% accuracy, and you already lose 50% to start with. So that's one issue that I have. The problem of erosion is it's a diagnosis of exclusion. You look at the culprit lesion, if you don't see evidence of recent plaque rupture, you assume this is erosion. It's a negative diagnosis, right. Very suboptimal. So what our group is trying to do is trying to develop AI model which will positively diagnose erosion. With that model, then we can detect erosion in non-culprit region. The hypothesis is patient came in with plaque erosion, he or she should have higher prevalence of erosion in non-culprit region. And rupture, same thing.
So maybe I go to Akiko. Can you explain, Akiko, in some of the studies done by David Erlanger and Ryan Matter, in STEMI, 95% of the lesions have very high lipid cores, big, large lipid cores, very yellow, rich plaque. But then we also see pathologically, we're seeing a third or more of cases of coronary thrombosis seem to be caused by erosion. Can you correlate these two facts?
Yeah, I think when we look into the near IVUS, mainly like the David Erlanger or like the Ryan Matter used, that even the erosive thrombotic event segment, there could be the lipidic plaque in the underlying segment. And also causing the thrombotic event, they should have some enough plaque burden. So even the erosive thrombotic event, we may have the lipidic plaque very deep side. So that's the reason why somebody look into only like the near IVUS may see the majority having the lipid-rich plaque.
Yeah, I'm personally still trying to figure this out, because when I talk to the pathologists, they say that erosion-prone plaques don't have a huge amount of lipids.
Yeah,
they may have
true.
small lipid pools, but you wouldn't expect to get a NIRS max LCBI 4mm of 300 or 400 or 500. So we're still trying to figure this out. Okay, so maybe we go to our experts on what is the ideal tool to detect a vulnerable plaque before it thromboses. Okay, what are our options? What is available today? Let's talk today, okay, in standard approved technology, both before the cath lab, non-invasive, and then in the cath lab. How can we detect vulnerable plaques?
So actually, this is very difficult. So at this moment, actually, we have very nice imaging modality, many nice imaging modality, but we according to any kind of imaging modality, we can define the high-risk plaque, vulnerable plaque, but we don't know how much it causes the actual acute coronary syndrome or thrombus formation, plaque rupture. We don't know. Presumably, based on the Ik-Kyung's registry, event rate is very low. So among the very pan-vascular vulnerable plaque defined by many different imaging modality, which would be the most dangerous vulnerable plaque, that subject we needed to further study.
Okay, so you've avoided my answer. Let me go to Akiko. Akiko, what is today's the best?
I think the gatekeeper has to be CT. And I think we know the CT, so-called vulnerable plaque, like low attenuated plaque, positive remodeling, that's correlated with the actual vulnerable plaque by intravascular imaging as well. So I think that's okay for the screening purpose and also the gatekeeper. And if you really want to the primary prevention, that's the right too, I think. Once the patient coming to the cath lab, I think that has to be intravascular imaging. And to me, personally, the best way, probably OCT. But I think OCT may not see the plaque burden, but recent OCT, so-called attenuation, like compensation of the attenuation, so making the plaque burden, even the OCT can be done. So altogether, I think probably OCT is the way to go.
So OCT, and with OCT, you're looking at the fibrous cap thickness. Mm-hmm. What's your criteria for fibrous cap thickness? And you're looking at the circumference of the lipid arc. What's your circumference that you want to see to call it a two-feature high-risk plaque?
Yeah, I think that Lenny is saying the 65 micron, but I think like we see some of the patients having the plaque rupture even 100 micron. So at least we can consider around 70, 80, 100. Those are the criteria, I think. And in terms of the lipid, based on the prospect 2, that's 350, around 350, that's about 1/3 of the arc, right? So I would think at least like 120 or something like this. Yeah.
And Dr. Jang, what do you think? You've done all this OCT work.
So, whatever, 20 years ago, when we came up with the definition of TICFA, that was based on Renu Vermani's work. Whether we can extrapolate histology data into living patient, that's another question.
Another question.
Yeah.
Yeah, most of her large plaques are at least 180 degrees circumference lipid, and of course the TICFA in a ruptured plaque is different in thickness than in a non-ruptured plaque. Jagat Narula would say 55 microns. He always says 55 microns. So I think we don't 100% know, and it's a matter of sensitivity versus specificity.
Yeah. So very important factor
we
that
performed the retrospective analysis,
Yes.
3,500 regions, non-carpet regions.
Yes.
And the cutoff of the fibrous cap thickness was 150 micron.
150.
150.
For what?
For future event, for future ECS.
that's already ruptured plaque.
Rupture.
Yeah,
Only rupture.
TICFA, ruptured plaque, they're
Yeah.
different.
Right, yeah.
And the lipid course size, lipid angle cutoff was 108.
Yeah. I think 65 is the most common parameter, 65 microns, and then it depends. It's very hard to measure these things, and there's a lot of artifacts, but that's for
That's a big question,
another
Greg.
day.
We talk about 65, 80,
Right,
whatever,
exactly.
but if you look at en face, there are multiple islands.
Right.
Yeah, so it is not like a 65 one area and the rest is 180. No,
Right.
You have one island 65 cap thickness, and if you go a few millimeters,
Right.
it's 80. It's all over the place.
Exactly. So should it be an average over the entire arc? I don't know.
What we did was, we had the algorithm, so we measured the area of fibrous cap,
Right.
which has thickness less than 65, 80, 120.
Right.
The total area, sum of.
Right.
So,
But theoretically, the thinnest point will rupture easily.
theoretically,
Yes.
yes.
Yeah.
Well, yes, that is possible, but if you have one little thin area and then it gets thick on both sides versus a longer we don't know. We don't know. And again, the limitation of OCT is through dense lipid, you often cannot see the external elastic membrane. And plaque burden in many studies has been the strongest determinant of future coronary events. So it's possible that if we have some of these newer combined modalities, whether it's maybe OCT NIRS or NIRS IVUS, then we can get a good sense of all the characteristics that are important, which seem to be plaque burden, amount of lipid, and fibrous cap thickness.
So,
Okay.
So because of such kind of OCT limitation, because on-site interpretation is very difficult.
Right.
In the cath lab, if there were Dr. Kubo and Akiko Maehara, if you are in the cath lab, we can analyze the cap thickness on-site, but not all the cath lab, you don't have such a kind of imaging specialist in the cath lab. So this is a big problem. So instead, the practically, I think the NIRS IVUS would be better than OCT because the NIRS IVUS provided the number, so lipid core burden index. So based on our PREVENT trial, so more than 315 lipid core burden index. So in such cases, the preventive PCI effect is better than the others. So NIRS would be the more practical than the OCT and others.
Yeah, the NIRS aspect is very simple. It's like a traffic light, right? It's hopeful in the future we're going to have AI-based systems that will give you a very rapid interpretation of a whole vessel and the entire plaque and integrate everything and give you a risk for that plaque. What about issues of plaque shear stress, endothelial cell shear stress? It may be more important, that if you've looked at some of the work that Peter Stone has done and other people have done, Habib Samadi, et cetera, you can take the so-called vulnerable plaques and then further risk stratify the ones that are really likely to destabilize and then get true positive predictive values of 20, 30, 40%. Okay, so are you believers in shear stress? Let's say plaque shear stress in particular.
So I have a question. So low shear stress is associated with the plaque progression.
Right.
And high
High
shear
stress is
Yes. What is the discrepancy? This discrepancy
the discrepancy in
for the future event. So high risk plaque should be high shear stress, but the plaque progression should be associated with low shear stress. So low shear stress has a great plaque progression, but a low risk of plaque rupture, right?
Well, plaques don't have just high or low shear stress. There are different areas in each plaque. Okay, often the low area of the shear stress is after the crest of the plaque, where the high shear stress is where the blood flow is actually hitting the plaque.
So in the lesion, there is a difference in the
There
low
are
shear
differences
plaque.
even in the lesion.
Okay, I see.
Absolutely.
Right, thank you.
So we studied shear stress with the plaque vulnerability.
Yes.
And the shear, after all, is just geometry, anatomy. When there is a narrowing, shear goes up. When there is no significant narrowing, low shear stress. And Peter Stone did a study. He correlated shear stress with anatomy and all this. He also measured cytokine and all those things. And there was close correlation between low shear and vulnerability. And also we reported the low shear region will progress rapidly in the future. So all bad stuff.
So I think personally from the work that I've seen, and I've not done this research myself, but from what I've read, this can be very useful, but we don't have a tool that we can make it easy to measure in the cath lab quickly on a routine basis.
It's coming, right?
But it's coming. So Akiko, what new tools do we need? Do you think our current tools are inadequate to diagnose vulnerable plaque, or are they okay, but we can do better? What are the future tools we need, both outside the cath lab to make CT better, and then in the cath lab to make invasive imaging better?
I think the most important aspect which we are missing is inflammation. So the by CT and outside the lipid, that's really good too. So that looks good.
So the fat attenuation index, do you believe in? Do you believe in that?
I do believe. Okay. But I think for the intravascular imaging, invasive imaging, is inflammation method is really lacking. Of course, we see macrophage, but if I diagnose macrophage and Dr. Kubo, we have different opinions. So very big inter-observability. It's very bad. So I think we really need a marker of the inflammation to detect of the vulnerable plaque. That's, I think, the missing. That's probably coming by either lifetime, OCT, or
the
other
FLIM.
factor.
Okay, so any other questions you would like about detection of vulnerable plaque? Otherwise, we should get on to possibly treating vulnerable plaque.
Before treating, the question that I have been struggling with is plaque characteristics versus plaque burden. What is more important?
I'm sorry?
What is more important?
Plaque phenotype versus plaque burden.
Is it the type of the plaque, or is it the burden of the plaque, or is it both? And which is the chicken and which is the egg? I think
both. But if I was asked which is more, I think plaque burden.
I think that if you don't have, we've shown very clearly, and all the studies are shown, if you don't have a large plaque burden, you're not going to have a clinical event.
Right.
But it doesn't mean that you might not have a subclinical event.
Oh, exactly.
Right.
That's what I said. Right.
Okay.
What the plaque rupture is determined by fibrous calf thickness. Clinical manifestation determined by plaque burden.
That
plus plaque disruption.
Right. I think overall I agree with that.
Yes.
Overall I do agree with that.
Yeah.
Okay.
So as I said, more plaque burden, more plaque, obviously multiple plaque, bigger plaque, higher vulnerability, chance of plaque disruption higher, obviously.
I think that's true. I think that's fair. But if you don't have a large plaque, you're not going to have
nothing's going to happen.
Okay, so let's get to treatment. Okay, if we find a vulnerable plaque, let's say you happen to do a CT scan, it comes back, it says this is a high-risk plaque, or if you're in the cath lab and you've got a non-flow limiting plaque which you've happened to image and it comes back with vulnerable plaque characteristics, should we consider treating it today? And if so, based on what studies? And if we are going to treat it today, would it be with medical therapy or PCI? What are the considerations that are in your mind?
If a patient on the cath lab table,
patients on the cath lab table.
In addition, the diameter stenosis looks significant, more than, at least visually more than 50%. There is just some vulnerable plaque by imaging. I think we need the stenting or other local treatment would be safe.
So you were one of the principal investigators on PREVENT. So based on the PREVENT study, if you find a vulnerable plaque that meets the PREVENT trial characteristics, would you go ahead and stent it today?
Yeah. Based on our QCA data, the mean QCA diameter stenosis is around 50 to 60%. So angiography very tight stenosis lesion, angiography very tight lesion. So plus and vulnerable features, why not? The contemporary DS is very safe. The BVS is not safe, I'm sorry, but the DS is very safe. Up to 5 years, event rate is only 1 or 2%. So why not? So DS implantation on the vulnerable plaque would be very effective and safe.
So you would be comfortable treating today. Dr. Kubo, what do you feel?
It's OMT.
So you would use OMT
OMT,
today?
even if
Okay.
we find that.
So if you find a vulnerable plaque, if the patient has an LDL of 60, what would you do for that patient?
Yeah, PCSK9 inhibitor.
PCSK9. How about if the patient has an LDL of 24 milligrams per deciliter? What do you do with that patient now?
So in those cases, if we found a vulnerable plaque, we may perform the PCI to the lesion.
Yeah.
Then you would perform PCI on a vulnerable plaque.
Yeah.
Dr. Maehara, what do you believe?
Okay, I'm not going to treat today by stent for sure, and optical medical therapy for sure. But if the LDL is 30, look for the LP(a) and look for the high sensitivity CRP, and that's going to be that direction. But still, we are not available drug yet for the
Right.
LP(a). So then treat, but yeah. That's a big question.
It's not about that. We're here to give big answers. Okay? So if you find a vulnerable plaque
Yeah.
and the LDL is 60 milligrams per deciliter, what will you do for that patient?
Do more. 60, we can do more.
So you would put the patient on a PCSK9 inhibitor, is that true? To bring the LDL down to 25? $1,500 a year for the rest of the life of the patient?
Not, yeah, okay. But I'm not going to stent, but I do think we have to look for other things instead of the LDL. So that's the most important. But we don't have a good,
But we don't have the good treatments
good
yet,
treatment
right?
yet,
Right.
but coming soon.
Right.
So that's we really have to look for. That's probably clinically most important instead of like thinking of the stenting.
Yeah. But I do think we have to take some of these financial considerations
Yeah.
into account. I mean, one thing I can tell you about the LP little a inhibitors is I don't know how effective they'll be,
Yeah.
but if they're effective, they'll be very expensive. Okay, more expensive than PCSK9 inhibitors. So, and again, they're not just a one-time treatment, they're going to be a treatment year after year after year. Dr. Jang, what's your opinion?
So there are a couple of things that we don't take into consideration. One is inflammation, and the other one is endogenous antithrombotic defense mechanism.
Yeah.
So this plaque healing, plaque progression is a continuation of plaque disruption healing.
Right.
When you have a robust antithrombotic endogenous system, plaque rupture may form a local small thrombus, no clinical event.
Right.
When you have poor impaired defense mechanism, plaque disruption, local thrombogenicity, and in addition to systemic thrombogenicity will lead to acute coronaries. So we don't measure, we don't know
Right.
this. So there are a few things that we have to take into consideration.
Yeah.
We are not looking at it.
Not yet. Well, so I'll give my opinion. So I think that if I find that vulnerable plaque, whether I was looking for it or not, I don't think we're quite ready yet to start treating. I think we had the Prospect Absorb pilot, which suggests it was safe and suggests we create a 200 micron new thickness of a neocap, which is much better than any drug, by the way. No drug creates 200 micron of a neocap thickness, and it delipidated the plaque, markedly reduced the amount of lipid. So that was all very favorable. And I think PREVENT was a great first effort and to show a marked treatment effect. But I think we need one more trial before we would routinely, one at least, one more. I don't know what to think about this 55% diameter stenosis, QCA. I personally don't believe the angiogram is important at all. It's the amount of plaque and the characteristics of the plaque. I think, PREVENT was a little unusual in requiring that the plaques were visually 50% or greater stenotic in the first place, so the ones that were less severe might have been a very different group of plaques. But I think, we're on the frontier, though, of starting to think about atherosclerosis and plaque very different. It's not just obstructive plaque that is mostly pathologic interval thickening or fibrocalcific disease that causes angina and dyspnea on exertion. We're now starting to think about the type of plaque that places patients at risk for cardiac death, myocardial infarction, and acute coronary syndromes. And I'm sitting here with many of the pioneers in this field, so a very exciting time. So I want to thank everybody, and I want to thank SJ and DW Park for inviting us to this 30th anniversary TCTAP to discuss vulnerable plaque. Thank you all very much.
Thank you.